year at NCI, and so Amar and I have gotten to know each other since that time. Oh, yeah, here we go. So let's see here. So I have no disclosures. I know I got to say that. And he gave you a little bit of my background. I did spend a couple years at Cornell, and then I actually transferred to Wake Forest and stayed on for med school. Did my internship at Louisville, OU residency, hybrid fellowship, like we said. And after fellowship, I had to stay in the D.C. area. My wife at the time was actually working in D.C. on Capitol Hill, so I wasn't able to sort of cast a wider net. There weren't a lot of academic opportunities, but Chesapeake Urology was at the time about a 40-man practice, a 40-person practice, and I was the first, fellowship-trained urologic oncologist for that group. And I stayed there for 3 years, and I'll explain why I left when I get to that part of the large practice part of this discussion. And I've been at the NCI ever since, and because the NCI is federal government, I do some locum work on the side as well, so I can actually afford to live in D.C. So this is me coming out of residency in 2005. I'm the guy on the left there, and my two co-chiefs, Gennady Slobodov on the right, and Jared Krusk in the middle. And when I was coming out, I had certain assumptions about the way the world worked and what things were, and basically broke it down into two categories. There was private practice and academics, and these were the ideas that I thought kind of went along with that. That in private practice you have more autonomy, you were kind of your own boss. You made more money, but you didn't really subspecialize. You had to be good at everything, kind of do a little bit of everything, whatever came through the door. But I wasn't entirely clear on which one had a better quality of life. In some cases with the private guys in Oklahoma that we would train with, they seemed like they had a really pretty good quality of life. Whereas in academics, you could subspecialize, really become an expert in a particular field. You got a chance to train, teach the residents, but you were obviously going to make a little bit less money, but you might have the chance to do some research. And, again, I wasn't entirely sure about the quality of life. It seemed like academics had a pretty good quality of life. But then again, when I, as a resident, would compare the private and academic guys, it wasn't entirely clear to me who had the better quality of life, frankly. So time passes, you sort of live your life. And, this is about 2 or 3 years ago. The three of us got together at the Oklahoma State Urology meeting. We're all fatter and hairier in this picture than we were 10 years ago or 12 years ago. And over those years, after living through some of the stuff that Amar alluded to, I realized that it's a lot more complicated than just private versus academic. When you talk about private practice, there's no actual one model, and I'm going to break it down into 3 models. There's multi-specialty practices, single specialty practice, and employed practices, and they actually each has its pros and cons. We're going to talk about them a little bit, or I'm going to try and touch on them a little bit. Whereas in academic practice, it's not a monolith either. You have academicians who are strictly clinical, and there are folks who do clinical and research, and then there are people who do research only, and that's a little bit unusual for surgeons, but they definitely are out there. And then when you talk about a single specialty practice, in our case urology, you can have a solo practice, which is, I think, going the way of the dodo nowadays. Small group practices and large group practices, and we'll touch on each one of those. If you're employed, you can be employed by the government, like I am, a healthcare system like Kaiser or Geisinger or one of those, or you can work directly for a hospital. So, and again, each one of these has its own sort of pluses and minuses, and we'll talk about each one. Now, this is where it gets kind of confusing, because on the academic side, you can, do clinical only through a university or an institution, or you might end up working for pharma, or potentially you can work for the government. That's kind of where I live, is that I'm in an academic practice, but I'm employed by the government. And then, of course, the question you have to ask yourself is, if you're working for pharma, are you really in academics, or are you in private practice? And where does that fit? So are you confused? Well, if you aren't, then that makes one of us, I guess, because I think it's a confusing picture. But in some ways, that the fact that it's a little bit unclear gives you a lot of options. So let's talk about solo practice to start with. I'm not going to spend a lot of time on this because I think it's kind of going away. There are significant startup costs. I think this is really, really tough to do nowadays. You can do concierge medicine, but typically that only works if you've been in practice for a while and already have an established patient base and referral base. I don't think coming out, that's really something that you can just start off doing right off the bat. I think it's difficult to manage nowadays in the area of capitated payments and accountable care organizations when you're a single provider, I think that it's hard to sort of find a place to fit in there. I do think it is possible in more rural areas, like if you're planning on, and you're the only game in town and you have a catchment area of 50 or 60,000 people, you might be able to just go out and hang a shingle and be busy right away. Certainly in a larger area like where I live in DC, I think that's almost impossible to do. The other way to kind of pull this off is if you find an older guy who's getting ready to retire and he gives you his practice. That's another way to kind of do this. In more urban and suburban areas, I think most of the solo practices have been bought up either by larger practices or by hospitals. And we'll kind of talk about why a solo practitioner might want to go work for a hospital when we get to that. Certainly, if you join a larger practice or work for a hospital, billing and coding is something that they can take care of for you. It takes a lot of time, particularly for those of us who aren't, maybe as adept at that kind of stuff, didn't learn it in their residency, and they're constantly changing the codes and that sort of thing. And keeping up with it is a full-time job. Obviously, if you want to go somewhere, this becomes tricky. If you're in a solo practice, you either have to get somebody to cover locums for you, which can be very expensive. You'd be amazed kind of what hospitals will pay for locums coverage. So it's lonely, and this is one of the things that I've heard from other practitioners who are out there on their own. It's like, I had a complicated case. It would have been nice to have a partner to bounce this off of, sort of talk about different approaches. Maybe somebody with different training might do this somewhat differently. And I think that as we go through our training, we're used to discussing cases and talking about things and kind of doing a rehash of the last case and what could I have done better, what could I have done worse. And it's, I think, more fun and more informative when you have somebody else to kind of bounce the ideas off of. So, small group practice. This is Jarrett Kruska. He and I finished about the same time. And he joined this practice up in Enid, Oklahoma. Okay, the other guy with the arrow is Jay Culver. He was actually my chief resident when I was a 3. These guys have a really good setup, I think. They're all similarly trained. They have a similar work ethic. They share the revenues equally. There's a lot of different ways that you can do practices. Some are kind of eat what you kill. Some are, everybody gets paid the same, and then that you get a bonus depending on productivity. And then there's more of a communist model where, the practice brings in X amount of money, and then you split it 3 ways or 4 ways. They're highly competitive amongst each other, which actually kind of works. Jared always laughs that particularly he and Jay, are always competing at the end of the month to see who brought in, did the most cases, who, saw the most patients in clinic and that kind of stuff. So it's a positive sort of competitiveness that I think works in this setting because they're all kind of rowing in the same direction, so to speak. Competition can be a real negative thing in some cases, and I can discuss that in the large group practice and some of my experiences with that. But they're in Enid, Oklahoma. I always talk to Jared about, hey man, I think you've got a really good thing going. And he's like, yeah, it's not bad. I'm making good money and I got good partners that I trust and I can travel, and when I do, I know my patients are in good hands and that kind of stuff. He's like, but I have to travel. I live in Enid, Oklahoma. There's not a whole lot to do here. And, so I see him periodically when he comes to DC or, at meetings and that kind of thing. And it's always kind of the same refrain. But it works because there's just there aren't a lot of people up there and there's not another practice in the area. There's no research, obviously. So if that's something he was interested in doing, which he never was, there's no outlet for that. And there's no teaching. There's no residents going up there. There's no fellowship or anything like that. So if that's something that's kind of part of your DNA, this is the kind of practice model that may not necessarily scratch that itch for you, and you may end up being a little bit unsatisfied if that's something that's really a part of who you want to be. And there's limited technology, relatively small patient base, relatively small hospital, and so, they don't have a robot. For a while he was traveling to Tulsa in order to do robotics, and eventually they got to the point where they said, we're just going to send all these cases out if you need that. They're not necessarily doing a whole lot of, prostate MRIs or fusion biopsies, and some of the latest techniques, they're a little slow to penetrate out in these less urban, less populous areas. But I will say, that he's been there since we finished in 2005, and he's been happy, and he enjoys it. He's from Oklahoma originally, and that works for him. So large group practice. So this is me. And, in 2008, I joined Chesapeake Urology Associates. At the time, it was about 44, I think, urologists. I think they're well over 60 now. They've expanded quite a bit, actually, in the 10 years or so since I left the group. Well, actually 6 years or so since I left the group. They started originally in Baltimore. It was 3 kind of medium-sized practices that banded together. And since then, they've become known as the urology practice that ate Maryland, because they now extend down into D.C., Southern Maryland, all the way out to Frederick. They go all the way up to the Pennsylvania line. And there just aren't a lot of other practices that are sort of independent from Chesapeake at this point. There was a large practice in the Bethesda area. They just bought them. There's another large, medium-sized practice that's in the Annapolis area, and one in the Greenbelt area. Not that these areas mean anything to you guys, that are still kind of holding out, but I think it's sort of a matter of time before they get consumed by this blob. They do get residents from the University of Maryland at at least one of their sites. And there is a research effort. They're big enough where they actually support some clinical research, usually pharma trials and that kind of stuff, equipment trials. It's called Chesapeake Urology Research Associates. It's based up in Towson. They're part of LUGPA, which you may not know what that is. That's the Large Urology Group Practice Association. So there are a number of these large groups across the country. There's one in, and they have different models. Chesapeake is a kind of a monolith. They have one administration, they have one sort of central billing area, and that kind of thing. There's another group in Long Island that's almost 100 urologists, but they basically share a tax ID number, and then they function as independent practices underneath that umbrella. So there's a variety of different ways to do it. There's another group out in Denver, TUG, the urology group, I think is what they call themselves. And they are different from Chesapeake in this way, which I'll explain in a minute why I think this might be better, but the one that's in Denver has a single location. Everybody comes to them. So they have, offices, an ASC, the research facility, the whole deal, and it's all in one building. And, the referring doctors send everybody to them, patients come to them, the doctors all work in one place. Chesapeake, on the other hand, is not set up that way, and I'll show you what I mean in a minute. They have lots of negotiating power. If the insurance companies say that they're going to start paying, 10 cents for a prostate biopsy, Chesapeake Urology drops them. And, usually 3-4 months later, they come back and they get what they want in terms of, prostate biopsy. Or, Lupron, they're for purchasing Lupron, they get a really steep discount because they're representing, 50, 60 urologists. And, within the Baltimore, D.C. area, they're covering, a couple dozen hospitals at least. So that works in your favor in a lot of ways. So this is kind of a map, and I actually had the map that they have on their website is incomplete, so I had to add a few extra dots, and I'm not even sure that this is completely up to date necessarily. But one of the things you need to kind of think about is the logistics of your coverage. So, and the logistics of your practice. So, being a young guy coming out, I think we all think of ourselves, I'm well trained, got lots of energy, I can do anything, it doesn't matter. I'll make it work. I was a resident, I've solved all kinds of problems, was up, 20 hours a day, that kind of thing, so it doesn't matter what you throw at me, I can handle it. Well, guess what? Life doesn't really work like that, and you have to kind of put these things into your algorithm when you're trying to figure out what kind of practice is going to work best for you. So I lived down here because we were sort of splitting the distance. My wife at the time was working down here, and so the closest, this didn't exist yet, and that didn't exist. And going from here to here actually is something you don't want to do because of the traffic in DC. So my clinic was here, and it was a community hospital that had just been bought by Johns Hopkins, which is sort of becoming its own health system now and buying up hospitals in the Baltimore, D.C. area. So I was doing a reverse commute, which actually wasn't too terrible. But this hospital was a small community hospital. I did a cystectomy there, and they said, oh, wow, we haven't done a cystectomy here in 10 years. And I was like, this might not be the place for me, particularly after having to deal with the ICU and kind of like coaching people through. So I ended up moving up my big open cases up to a hospital right inside the Beltway here, but they didn't have a robot. So then I was out here in Glen Burnie doing my robotics. And at one point, I was driving about 100 miles a day, and every time you get in the car, you're losing money. It's wasted time. It doesn't matter whether you're motivated by family time, RVUs, your check at the end of the month, whatever it is, it's wasted time. Wasted time. Okay, so I had a daughter at the time. I mean, I still have a daughter, but she's not as young. She was probably 3 or 4. And, I hardly ever saw her because, I would, run from clinic here and then do some cases over here. And then I have to run over here to round. And then maybe I get called back here to go do this or that or whatever. And then, of course, I got to come down here to go home. The Beltway always sucks, basically from 3 until about 6 p.m. or 7 p.m. And so this distance from where I was living to 95 is usually like a 5-minute drive. It would take me like 40 minutes at the end of every day at a long day. That's not sustainable. You can't do it. It wasn't going to work. And so, had I been a little bit smarter about these things coming out, what I probably would have done is insisted that I just end up over here. The one guy who was doing a lot of oncology in Chesapeake was based over here, which is where the robot was anyway. And, he was supposed to be a mentor for me. He was kind of a mentor for everybody in the group. He had been the chairman at University of Maryland before he left. And was interested in academics. This is where the Maryland residents would actually come down and rotate. And if I had just done my entire practice here, I might still be with Chesapeake. They had a research nurse, even though the research apparatus administration was up here. They had a research nurse down there. They were opening some pharma clinical trials, and just a one-directional commute, maybe not so bad. One of the things I learned about this in the time that I spent is that I hate commuting. I hate it. So that might not have been sustainable anyway. But, these are things I didn't know or didn't think about when I was coming out. The other thing that you have to kind of factor in is how they break up call, right? So, these are a lot of different facilities, and there's no possible way from here or even from here you're going to cover it up here. So they break up the hospitals actually into pods. So you have 4 hospitals in a pod. And this was the other hospital that was in our pod was up here right on the water near Inner Harbor. So these are the 4 hospitals that I was covering. There were other guys that had 4 hospitals that were all bunched up right here. That makes a big difference when you're on a weekend because you're covering, we had 4 providers here, 4 providers here, 3 providers here, and 2 providers over here. So that's a lot of urologists that you're covering patients for and a lot of ERs. And so you get up in the morning, you drive up here, you round, you see whatever, then you go up here, you kind of see, the 2 or 3 patients that got in there. These 2 dudes were mostly clinical urologists and didn't want to do big cases, so the big cases that were up here were actually mine, so I had to go there anyway. And these guys were sort of intermediate, and this guy did a lot of big cases or a lot of cystectomies and stuff there. So, I would get up here, I would round, see the sling or whatever that was done here, drive down here, see the cystectomy or what have you, then start heading home because, I sort of do a loop like this. And usually right about here, I would get a phone call from this ER, and I have to turn around and go back. And that was my entire weekend. So I would just leave in the morning at 0700 or whatever, and I would get home, usually 8 or 9 o'clock at night on a weekend, which, if you're doing that once every 8 to 12 weeks, maybe that's not the worst thing in the world. But it's not a great quality of life, when you're factoring these things in terms of quality of life. That's not the best existence. There were 4 people who joined the group the same year I did. A gal from the Mayo Clinic, one who'd done where's she? She's on staff at Minnesota. Anyway, it doesn't matter. And a guy who'd done the Lipschultz Fellowship. Only one of us actually stayed past, through our first contract. The guy who did infertility. And he's still with the group, and he's now a partner. The rest of us left and kind of went on. I'm at NIH. Kristen is now on staff at Minnesota, and the Mayo Clinic gal went out to California. So you got to think about the logistics of not only your practice, but the coverage and which hospitals you're covering. You got to think about cohesion. I talked about in the small group practice, my buddy Jarrett's practice, they're really tight. They know each other. They trust each other. It doesn't really matter. In a situation like this, you have a lot of different degrees of training I was the only fellowship-trained urologic oncologist, but the guy that was out here doing cystectomies was, functionally a urologic oncologist, had been a chairman, worked for years at Maryland, kind of knew his stuff. He and I were totally on the same page. I loved doing cases with him. His name is Jeff Sklar. These two guys, I remember I did an early case. It was like a 15-year-old girl with a 15-centimeter renal mass. I did a nephrectomy on her on a Friday. And I get a phone call from one of these guys who shall remain nameless. He's like, normally we don't do big cases on Fridays, because then we got a round on them over the weekend. This is like my second week in practice, this is not something that they were interested in rounding on. And of course, then I felt guilty, and so then even when I'm not on call, I'm going up at least to see my patients because, I'm not sure what these guys are going to do with them, and they don't know what to do anyway, and they're going to ask a hospitalist or something. It just doesn't work. They're not going to manage your patients the way you want to manage them. So that gets a little bit tricky with the bigger the group, and particularly when it's as large as it is, it's really hard to find, a group of people that are going to, you can't find 3 doctors to agree on anything. Imagine if you got 15 or 16 that are kind of covering your patients. So the highly variable training, one of the advantages here, unlike the smaller groups, is that you can subspecialize. We had people who kind of predominantly did female urology. I was trying to do urologic oncology. In a group private setting practice like this, I started off probably doing about 30% oncology, and then the rest was sort of general urology. I kind of stuck to stones and BPH because I had some female partners here, partners who did female urology, and I didn't particularly care for that. So I was able to do that from the outset. But by about 3 years, I was doing a little over 50% oncology, and the rest was sort of general urology. And so there was a possibility to do that. In a smaller practice, and certainly in a solo practice, it's almost impossible to do that. This can be a really, really good internal referral source. So the guy that I was telling you about here in Glen Burnie, everybody knew him because most of these folks had trained either at the University of Maryland or at Hopkins. He'd been the chairman at Maryland. And so, cystectomy up here, they'd send it down here. Cystectomy over here, they'd send it down here. And so he basically got all the cystectomies funneled to him from the, outer ring of Baltimore area. So he was a busy cystectomy guy. He was doing, 2 a week, which in the Baltimore area is actually a lot. There would, you would think that, between Hopkins and Maryland, they would kind of vacuum up all the cystectomies. That's not what was really happening. Basically, the cystectomies all followed him here, and the cystectomies that were coming to Hopkins were actually coming from outside by and large, or from within the city itself. So, so that can be a good and a bad, because when you're the new guy and they're established, referral patterns like this, they're not going to stop sending their cystectomies to this guy and start sending it to some new dude who's over here in some other site where they don't normally do cystectomies anyway. So again, you got to be smart. If you want to do this within this kind of setting, you have to kind of see where the referral patterns go. In the cases that you want, you probably ought to just set yourself up and hang your shingle there, rather than try and, get all these established guys who've been doing this for several years to change what they're going to do. You kind of need to adapt to them, not the other way around. It's not really going to work. Now, this is what I alluded to with the group in Colorado. Colorado, they have one site everybody sends into them. Here, you got an office here, office here, office here, office here, office here. That's a lot of overhead, a lot of staff, a lot of nurses, a lot of MAs. At one point they had up here in Towson, because like I said, they sort of merged some practices. They had 2 office sites that were less than a quarter of a mile apart, which doesn't make any sense at all in from an economic standpoint. So there was a lot of administration, and they were sort of working out the kinks when I was there. They're still relatively new. I think they've streamlined a bunch of that stuff. But still, when you have this kind of scattershot model like this buckshot model, you're going to have a much, much higher overhead and much higher administrative burden as a result. And, that comes out of the money that you bring in. There are great ancillary sources of income, and this is something that you really can't do nearly as well in the small practice setting. It's almost impossible to do as a solo practitioner, if not totally impossible. They were going through some litigation in Maryland about their CT scanners and their radiation center. So they had their own radiation center, and so all the external beam IMRT was going to a radiation center that was owned by the practice, which is a great source of ancillary income. And the radiologists and the radiation oncologists sued saying that this was a violation of Stark laws. What they ended up doing is divesting themselves of the CT scanners, but they were able to litigate and keep the radiation center. They also now not have a full-time pathologist on staff. They do all their path in-house. And they do, they have some lab stuff that they do in-house as well. So it started off as a single specialty large group. It's becoming kind of moving toward a multi-specialty, but really with a urologic focus. And of course, the people who are running the practice, or at least were running the practice, were urologists. And so they were kind of keeping that at the top of the list in terms of what was going on. So, there's a lot of possibilities here when you join a large group, but there's also some significant downsides that can go along with it. So, multi-specialty groups. So, the nice thing about this is that you have a large contained source of patient referrals. You have a built-in network of, primary care providers who are sending you patients just internally. That's just kind of how it works. The billing and administrative issues are handled for you. I think Merritt Hawkins showed that urologists who work in multi-specialty practices actually make the most money on average, compared to single specialty groups and academics. But you're not your own boss, and your boss more than likely isn't a urologist, may not even be a doctor, and so that changes the priorities of the financial priorities in terms of what they're going to support. In this model, you're going to be one of the people that floats the boat, because there are certain specialties that don't necessarily make as much money as urology does, and so some of your money is going to end up going to that. You don't have as much control over your clinic and schedule than other models. Because of this, but you have no issues with Stark laws because you have multiple specialties within there. The idea of referring to yourself is a non-issue. If you send them to radiation oncology, that money kind of stays in the same umbrella. If you send them to interventional radiology, that stays within the same umbrella. So all the money kind of goes into one place. Now, do you know Doug? You know Doug. Yeah, I was going to say, he was a resident of Georgetown when you were at NCI. So Doug, I think, is an interesting example of somebody who kind of started in one model and morphed it into something else. I know Doug because at the time that I was coming to NCI, he had just finished at Georgetown, and he was doing a one-year robotics fellowship at GW. It's a fellowship that doesn't exist anymore, but he and I got to know each other. He ended up finishing the GW fellowship and going out to Tacoma to a multi-specialty group. He was one of two urologists at that time, and he worked his buns off. Did very, very well financially. Was making a lot of money in a very short period of time. And what he was able to do is he quickly rose. It's a lot like what Amar has done here. He kind of rose to a position of leadership within the multi-specialty group and was able to hire a handful of other urologists to work within the Department of Urology within this multi-specialty group. And then there's a local military hospital there, and I can't remember the name of it off the top of my head. I was sort of racking my brain last night. And he was able to get residents that now rotate over there, and he has, fellowship-trained subspecialists at his multi-specialty group. And so, he's done very well, and he's actually kind of morphed it into this hybrid academic program when initially started, strictly private practice, kind of doing everything. And now he basically does, minimally invasive oncology primarily, and he's not necessarily doing a lot of general urology at all, but that's how he started. So, again, this is where some of the savvy comes in. You have to be able to recognize opportunities, and you have to be willing to work to shape it in your image. And I think that's a little bit easier to do if there isn't something that's already established and in place. It's much harder to change an existing structure than I think it is to build something the way you want it if there isn't a whole lot going on there. So employed practice, I'm not going to spend a ton of time talking about this. If you're hospital employed, the nice thing is there's one site that you work at. Now, sometimes with some of these other things like the large group in Colorado, that's also true. But in most cases, most of the docs that I know are covering a couple different hospitals. You get to know all your fellow physicians pretty well. because you're all working in the same place and you're all employed by the same place. You don't spend any time on overhead billing and coding, which is a plus and a minus. You don't spend the time, but they may not necessarily be billing and coding the way you would, and so you may end up losing some money there, which is a little bit of a trick, and that can be true of other practice models as well. You also don't control your nursing staffs, your MAs and so forth. They're hired by the hospital, and so that can be a little bit of a problem for you there. You don't have any negotiating leverage really to speak of. Your hospital has all the leverage, and whether or not they want to use it on your behalf, it probably depends on how much money you're bringing in. But it also depends on what their other priorities are. They have a lot of other physicians that they're also employing that have needs as well. Your pay is out of your control. This is one of the knocks that I've seen on this, is that you sign a contract, there are certain parameters, and then when your time comes up to renegotiate your next contract, if you're doing really well, you may or may not be able to improve your pay. If things aren't going the way they want, or if the hospital's suffering, they can basically change things, and then you have to decide whether you want to stay or not, because you may not. You may have to work harder to get the same amount of money or make less money, and it's a little bit tough because again, you're just an individual negotiating with the hospital. You're not necessarily a group. And it's all about revenue hospital-wide. The more you bring in, the more you're going to get from the hospital. But you will probably float the less lucrative specialties if that's an issue at your hospital, which it is at a lot of hospitals. Healthcare systems. So there are a lot of different healthcare systems. They're all set up a little bit differently. I'll talk about Kaiser because I kind of know a little bit about that, and I'll talk about MedStar, which is a smaller system. So you got Kaiser, which is a real big system, and then MedStar, which is a little bit of a smaller system, and they're set up very differently. So at Kaiser in the Mid-Atlantic area, they pay their urologists the 75th percentile of MGMA, and you can get a bonus on top of that for fellowship training. So that's pretty good. You have really, really limited autonomy. You don't necessarily get to pick where you're going to work. You don't have any control over your schedule. You're expected to be there from, 8 to 5 or whatever it is, 8 to 4, I guess. And if you finish, your clinic, you have 25 patients in the clinic and you're done at noon, you still have to stick around. You don't get to go play golf because they'll fill those slots kind of on an ad hoc, ongoing basis. And so if there's a urology patient that's seen by a primary care doc in the Kaiser system near you, and the primary care doc says, "Oh, you need to see a urologist." "Oh, hey, we have an open slot at 2:30 this afternoon." Guess what? You're seeing that patient, and it doesn't matter what it is. You might be urologic oncology trained, but if that's a leaky woman with an interstitial cystitis, which is like my nightmare, sorry. You're going to see that patient. Now, you may end up referring it to one of your partners later to kind of get the rest of it managed, but you're there until 4 o'clock, whether you're done or not. And that's something that people don't necessarily love about that. There's no productivity incentive whatsoever. They do keep metrics on your productivity, and if you're not meeting whatever their standard is, they can get rid of you. But you're not making any extra money if you work harder. If you see 50 patients in clinic and you have a partner who's seeing 20, you're both getting paid the 75th percentile either way, which can be disheartening sometimes. Again, this comes back to the kind of, and you're not necessarily picking your partners. You get some say in that, but it's not like a practice where you have, the kind of the final yay, nay on perspectives. It doesn't really work like that in the Kaiser system because you're not the one that's, necessarily making the final decision. The one big benefit to Kaiser, not only do they pay well up front, this is pretty good money, but there's a great retirement plan. And that's pretty much universal, across the board, whether you're talking about Kaiser in California or the one in the Mid-Atlantic. They have a great, retirement plan. I don't know all the details about it, but I know that it's extremely lucrative and they do very well. And it's a good quality of life. These guys are pretty happy. They basically work kind of a 9 to 5 schedule and that sort of thing. MedStar, they run 9 hospitals in the DC-Baltimore corridor. They have a set contract. I think this is true for some of the bigger, hospital systems. There's a single set contract. If you want to negotiate this or that, they really don't do that because they're like, that's not how we do this. We hire all our urologists the same way. This is a standard contract. Take it or leave it. They're compensation, unlike Kaiser, is productivity based. So you get a guarantee for a couple of years, and then basically based on your RVUs is what you make. You get a very low base salary, and then basically everything you make after that is based on RVUs. They cover both academic and private hospitals, but it's academic in name only. They may have residents or what have you, but there's no research going on there really to speak of, whether it's pharma research or R01 type research. It's just there's no incentive to do it. Because you're not being measured on that at all. There's no bonuses for academic productivity. It's basically how many patients do you see, how many cases do you do. You don't really have any control of your clinic staffing or where your clinics are located. If they open up a satellite clinic and they want a urologist to go out there, guess what? They're going to tell you that's where you go, and that's where you go. And you don't have any control over billing. This can be a problem. Again, you have to really work with them, I think, to make sure that they're billing and coding things the way you want them to. And even if you do work with them, that doesn't necessarily mean that's what's going to happen, because you're not necessarily working with the same billers every time. You do have a great regional referral base. All these clinics and hospitals are within the kind of the MedStar system, and so they can funnel patients to you if you happen to subspecialize. Government, this is what I do. There's a bunch of different ways to work for the government. You can work for the VA, which can be academic-ish. I mean, we've all rotated at VAs, most of us anyway. You can work for the FDA, which is a different sort of kind of practice, really not clinical. You can work at the NIH like I do, or you can work through Indian Health, which may or may not actually be called that anymore. There's good benefits. It's not the greatest benefit package. Everybody talks about the government benefit package. It's not like it used to be. When Marston Linehan, who's been at the NIH since 1982, got there. Basically, if you work 20 years, you get 80% of your 3 highest salaries for life. It's pretty good. Yeah, I mean, that's great. Yeah, they've changed that now. Now it's like 1% a year for every year of service or what have you of your 3 highest. So I mean, it's not terrible, but it's not like the money pit that it was. But you're only expected to work 40 hours. Which is fine. I mean, that's not necessarily what we do, but that's all you're expected to do. And if you decide I'm only working 40 hours a week, they really can't make you do a whole lot more than that. You get every holiday imaginable, and some made up ones too, it seems like. And you get good vacation. At least working for the NIH and the VA, the malpractice thing is kind of a non-issue, which is nice. The government has to agree to let you sue them. There is a way to adjudicate malpractice claims. It's very, very confusing, but you're not really on the hook the same way you are in private practice or even academic practice. There's very slow to almost no prospects for advancement because it's kind of a good gig, and you have folks like, I said Dr. Linehan's been there since 1982. The guy who hired him is still there. He's been there since 1976. So if you're under those guys, there's no moving up. You got to kind of move out, not up. It's way below average pay. The VA is much better than NIH or FDA, but it's still not, even 50th percentile of MGMA. There's absolutely no productivity incentive. You can come in and do nothing. You're going to get paid the same as if you crank in as many cases. And one of the challenges with that is if you want to do as many cases as you can, well, that's fine, but nobody else does. So, your anesthesia colleagues are going to find any reason they can to cancel your case because then they get to go home early, So, and of course it's under the guise of patient safety. I mean, this guy had a, upper respiratory infection 2 weeks ago, but I still hear a crackle, so we're going to cancel it today. That kind of stuff. I mean, you see that. Anybody who's worked at VA kind of knows what I'm talking about. There's a built-in patient population. Certainly the VA has it. Indian Health obviously has it. And then, the NIH, because of the research protocols and the very special patients that we take care of, they come from all over the country and all over the world. So, you're never looking for patients. They're coming to you. And so that's kind of a plus. And there's an opportunity to not just subspecialize, but subspecialize if you want to, and become the world's expert in something really, really arcane and kind of like what I do actually. And develop highly unique expertise, which is definitely a benefit. When I was a resident, I saw one VHL patient. I see like 20 a week now. I'm doing, when I do a partial nephrectomy, I do most of them robotic now. That's the one thing I can say I contributed to the NIH is that We converted our partials from mostly open, probably about 80% open. They're about 80% robotic now. We average 8 to 9 tumors per case. You just don't see that in the real world in that kind of volume. But I mean, we're seeing 20, 30 patients a week with that, and we're doing 2 to 3 of these cases a week. So it's neat. You sort of ask yourself, well, when you get out in the real world, what kind of applicability does that have? Well, the only thing I can say is when you do a second time in, third time in, fourth time in kind of operation like that, then the first time in single tumor case is kind of a walk in the park, which is nice. And one of the things you'll find in government, it's certainly true at the FDA and the NIH, I don't know about the VA so much, is that there are a lot of people who are interested in power and prestige. They're not getting paid. And so it's more about title and accumulating resources. How many nurses can I have under me? How many doctors do I have that are working under me? And it's more about kind of protecting your turf, so that because that becomes a motivator, and whether or not you're like a clinical director or subclinical director or whatever it is, and that kind of motivates people in a way that you don't necessarily see in other practice models, I think. And then it can be very, very interesting work. If you have a thing that really gets your juices flowing and it's kind of unusual, this might be the thing for you, at least for a while, because it's the one place where you can take the resources that are available to you and bring all those patients. You can pay for them to come to you and really study them and actually make a contribution. So if that's the kind of thing that motivates you, it can be a really, really great job. And it's certainly a great place to be a stepping stone to other things, as we've seen with some of our colleagues. Clinical only. Now this side, okay, whoops. So my animation's kind of stuck here. So true academic practice. I think this is becoming more and more rare for a variety of reasons, but you're affiliated with the university. You have protected research time. You usually start with some internal funding initially, but you have to get external funding or it all goes away and then you become, clinical only. And it's really, really tough to wear two hats. To become, a really good surgeon takes volume. You got to practice. You got to keep doing cases. And if you're spending half your time in a lab with petri dishes and torturing mice and that kind of stuff, it gets hard to achieve that kind of level of proficiency, the kind of proficiency that you need. It can be done, but it's very tough. But it is the ideal paradigm of the surgeon scientist. These are two guys, Amar knows this dude. This is Sunil Sudarshan. This is a guy that I trained with at MD Anderson. I think they're both those rising stars that the AUA have. And they both achieved, R01 status funding. They both are about 50% clinical. I think they're both excellent clinicians, but they're also very distinguished translational scientists. And
Neil operates at clinical work 1 day a week. He's at UAB.
Yeah.
1 day a week.
So he initially started at, let me go back. He initially started at San Antonio, and then he's now at UAB. Peter's up at University of British Columbia. He's been there since he finished fellowship. I think he's maybe like a little more clinically busy, but they both have gotten external R1 type funding and are doing really, really great work. And the thing that I think is really important about this, and one of the reasons why I think it's important that we need to support this idea, and if you want to do this, you should at least take a shot at it, is because a clinician, and a surgeon in particular, has a different perspective than a PhD. So we can't really abandon research to the PhDs. They're not going to ask the questions that are actually clinically applicable. They might be really interesting intellectually, but they're not necessarily going to make a huge difference in terms of practice. It's the people who are actually doing the operations and taking care of the patients and seeing what these patients are going through that will formulate questions that are actually going to improve quality of life and potentially extend quality and quantity of life that PhDs and non-surgeons just won't come up with. And so I think that these guys are a real treasure if they can pull it off, but it's really, really tough. And one of the reasons is, over the last 15 years, the amount of money set aside for research funding has gone significantly down. And the pay line, what that means is your grant gets a score. And it used to be that the top 20% would get funded. Now it's the top 10%. So there's a lot of really, really smart people with a lot of really, really good ideas who are close, 89%, 88%, and they're not getting funded. And if you don't get funded, you can't run your lab. the hospitals, the universities are only going to fund you for so long, and the money that they give you is not going to be the same kind of money you can get from an R1 grant. And there's a whole process. You start with K grants, you work your way to R grants and that kind of thing. But it's getting increasingly hard. And as a surgeon scientist, it's really hard because you are clinically busy. You're not a PhD. Your job isn't to sit in the lab all day and write these grants. So you're really wearing a couple of hats and juggling a lot, and it's not so easy. And there's a greater pressure to self-fund. People used to have a much longer leash to get their R1s, and they don't now. I mean, the window is 3 years. If you get a little K grant, it might go to 5 or thereabouts, but you really need to be kind of getting R level funding or some other kind of funding in that time, or they're going to say, you know what, you just need to go see patients and take care of patients and start bringing in money that way. Good research takes time. Failure rate is extremely high. Not only people trying to do this and not doing it, but you have to be ready to run down a whole bunch of dead ends before you find something that actually has traction and looks like it's going to make a difference. And so it takes a lot of patience. Promotions and salaries are related to your publications, the impact factors, and that kind of stuff. Because of that, sometimes there's been a move toward publishing a lot of small, lower impact manuscripts, as opposed to if you look at some of the truly great researchers, they don't have a big long CV with 100 publications. They have 2 or 3. But it's Nature, Cell, New England Journal, and that kind of thing. And that doesn't fly anymore. That's not how you're measured in these true academic practices, unfortunately, particularly in urology, because the dean doesn't really know the difference between urologic oncology and the International Journal or Brazilian whatever. It's just a publication. So. And they will look at impact factors and that kind of stuff. But at the end of the day, these pressures have drawn people away from really spending 5-6 years to get one really good publication. It's hard to justify doing that now. And I love this. I actually have this in my office. If we knew what we were doing, it wouldn't be called research. You're going to spend a lot of time asking a lot of questions that end up going nowhere. But the only way you find out is to ask the question and then try and answer it. So these hybrid practices, I think, are becoming more and more common. You have an academic appointment, but you're actually not affiliated with the university. You're being paid by, a practice group. This is the Medical Faculty Associates group at GW. You do train residents and fellows potentially, but basically it's an eat what you kill kind of model. 60% of what you bring in goes to the practice faculty, associates, whatever, 40% goes to you. But there's no dean's tax, so, when you're in a true university, the dean's going to shave, 15, 20%, 30%, whatever it is, right off the top of whatever it is that you make. And there's no actual affiliation with the university, as I said, and you do research on your own time. If you want to do an abstract or whatever, it's nights and weekends, man. Because when you're at work, you're seeing patients, you're going to clinic, you're doing cases. Research only. I touched on this a little bit before. This is almost unheard of for a surgeon. I mean, John Jarrow was at Hopkins. I think he was sort of a fertility guy for a while. Then he was doing prostates. Now he's like at the FDA and sort of reviewing, new devices and drugs and that kind of stuff. But that's pretty unusual. Typically, this is the realm of PhDs and MDs, the two together. You're more likely to do this in industry if you're working for a technical company or pharma. I don't think it pays particularly well initially, but if you kind of work your way up in pharma, it can actually be, fairly lucrative. It's nice regular hours. This is a 9-to-5 job, and there's no emergencies. It's not like you're getting called in the middle of the night, which is nice. A buddy of mine from college who actually, was kind of a degenerate, like I guess we all were, but, then grew a brain and went to med school and became a pediatric oncologist, did a fellowship at Dallas Children's. And he's actually doing something like this. He realized that he wasn't going to be able to find a practice where he had the kind of support he needed to do the kind of work that he wanted to do. So he ended up going the pharma route. And he's had a really nice experience. He reviews grant proposals and reads them, decides what they're going to fund, what they're not going to fund. And then as he moved up the chain, that's initially what he did. Now he, actually runs a molecule. So, from phase 1 trials through phase 4 trials. It's kind of, he's in charge of deciding who gets to do what where and that sort of thing. So it's interesting work, but you don't necessarily get to control the decisions because those are made more financially than from a scientific interest standpoint or medically. If it's medically a drug that's going to help, but the market niche isn't there, they're not going to pursue it, and so you're sort of out of luck, even if you think it's the right thing to do. He's moved from one molecule at one company to another molecule at a different company. So, from that standpoint, he's developed a set of skills in terms of bringing these things to market and figuring out which are winners and losers. But, it's not like a disease process or taking care of patients anymore. The pay is very good. The lifestyle's great. I remember calling him. He's like, oh, yeah, I just got back from a run on the beach. He was living in Malibu at the time. Now I got to read a couple of grants, and, that's going to be my day. And I was like, I was in the middle of my residency at that point, or fellowship, I think, and I was like, oh, man, I made the wrong decision. but I think this would be tough to do for a surgeon, particularly if you like being in the OR, you like procedures and that kind of stuff. I think a lot of us would go stir crazy with that. So the real question is, what do I want professionally? And I think that I would like to think anyway that I've shown you that you can adjust some of these to fit whatever it is that really floats your boat. You want to find a practice with strong leadership, with vision, unless you're going to try and build something on your own, but you have to be willing to do that extra work. You want to find really, really good partners that you trust, that are going to do things the way you would do them even when you're not there. It helps you sleep at night, and it helps you enjoy your vacation. You need to kind of look at pair mixes and that kind of stuff. You need to make sure that you're going to get paid for the work that you do. And you want to spend your time practicing medicine, presumably, and not running a business necessarily. I mean, I don't think that's what any of us went to med school for. And you need to figure out kind of what role call plays in your life and how big of a deal that's going to be for you. They did a survey of residents, what's the most important to you? I think most people say time for family and personal stuff, and adequate support services and that kind of thing. So you need to figure out where you fall on this list, and then find a practice that will allow you to have the things that you want. You want to make sure that if it's an existing practice, there's a strong business infrastructure, that they're not just letting money run through their fingers and that you're not going to get paid for the work that you do. You need to make sure that they have a market strategy. How are they going to maintain their position and grow it? You don't want to go into a practice and be the only young guy. That makes it kind of tough. You need to have peers, not just colleagues, people that you're going to kind of grow with as a group. There's always more friction when there's a lot of disparity. You got the old guard and then the new blood and that kind of stuff. So it's nice to have a mix, and certainly some folks that are kind of more your age and similar training. There are some benefits to private practice. I think you have a little bit more control of your destiny. You can sort of shape things the way you want. I think initially the compensation is higher, certainly than academics and the federal government. Is there an ideal practice? Again, I think that's really up to you, but you have to have patience. I think this is tough for us as surgeons. And when you get out there and you're starting to think about what practice is going to work for you, what do you want to do, talk to as many people as you can. The more people you talk to, the more models you're going to hear about, and you're going to be able to kind of cherry pick the stuff that you realize kind of matters to you as much as you can. And you want to take the time during your training to learn some of the business of medicine. I never wanted to do that. I knew what a 22 modifier was, I think, when I was a chief resident, but that was about it. You need to do a better job of educating yourself on that side of things, because that is really going to be how you get paid when you get out, particularly if you go into private practice. And if you're not counting your pennies, somebody else is going to count them for you, and you're probably going to get the short end of that stick. So I don't know if anybody saw City Slickers. I mean, this is really old. Guys might not even been born when this came out. I'm not sure. But that's Jack Palance, old actor. And the premise of the movie is that you got these New Yorkers that go on one of these cattle runs, like dude ranch kind of things. And he's this old grizzled guy, and they asked him what the secret of life is. And he said, it's the one thing. You got to find the one thing that matters to you. And I think that works for how you're going to set up your practice eventually. What is it that you want? What's the one thing that makes you happy? Because if you get that out of your practice, you can work with some of the other stuff that maybe you don't love. But if you're not getting that one thing, the thing that really gets your juices flowing, you're going to be unhappy and you're going to want to make a change relatively quickly. So that's, I think, the hardest thing, particularly when you're young and you sort of think you can do everything and you're easygoing and it doesn't really matter, because you can handle anything. You may not necessarily recognize what that one thing is that gets you going in the morning. And so if you can spend your time and figure out what that is, you can find a practice, because there's obviously a myriad of practices out there that will give you that one thing, and then hopefully a few other things that will make your quality of life such that you don't hate going to work, that you actually really enjoy it, and that you're happy being there. And I think your boss is a great example. If you're persistent, you work hard, you maintain an idea about what you want, you can build something if it's not there already. And so I think that you have a tremendous resource here in Dr. Singh, because, he's been through a couple of different versions of a practice, from where he started to where he is now. So I think he's got a lot of insight there. So thanks for your time. I hope, and if you have any questions, don't hesitate.
Any questions?
Yeah.
What's the thinking within the NIH about the VA system? Is there...
So they're two separate systems, and they're both under the Department of Health and Human Services. But I think that I always call the NIH sort of the mothership of the VA, because there's a lot of the negatives that I found when I was a resident at the VA in terms of lack of productivity incentive and that kind of thing. But at the NIH, the research is such a focus that you get a lot of really motivated people who want to advance the research. And so you have more of a dichotomy there, because you have some people who are extremely motivated to get their research done, but at the same time they get a little bit myopic about that. And so in some cases, the clinical side of things gets neglected for the research side. Not neglected, but it's secondary as opposed to primary, like it is in other places. As far as what specifically about the VA do you mean? They're really two separate entities, so I don't think that people who work at the NIH really think a whole lot about the VA, frankly.
I've thought they should disband it and give everybody Medicare.
Oh, I totally agree with you. I mean, that's another talk for another day. I think the VA is the biggest waste of money. Oh, it's the biggest waste of money, I think. But the problem is the veterans don't know that. They think they have this thing that's really, really special, and they have a very strong lobby. And so getting rid of the VA is really, really tough, because the veterans will be up in arms about it. I think we can do a better job for them. I think we should do a better job for them, frankly. But I think that, this scandal that they had out in Arizona, that's just the tip of the iceberg. Anybody who's worked at a VA kind of knows that that's like more par for the course than the exception.
Speaking of VA, I remember when we were in training, there was something came out at Stony Brook, and I think part of urology was implicated. And Stony Brook VA had a golf course in the back, and some patient died on the table, or some bad, horrible thing happened while the attendants were on the golf course, and they were not anywhere to be found. So
Yeah.
it's not just one place, depending on. But having said that, there are certain VAs that run like very well, and there are majority that run just
Terrible.
extremely suboptimal.
Yeah. Well, and some of them are a mix of the two. When I was in Oklahoma, the VA was right next to the University Medical Center. I mean, it was all like walking distance within a 2-block radius. And the best ICU out of the 4 hospitals that were there was actually at the VA. But we used to sometimes discharge patients from the ICU, because if you took them to the floor, you might as well roll them in the parking lot. Like they weren't going to get paid attention to at all. So it's a problem. And it was a huge hospital. I think it was like supposedly 800 beds, but the top 3 floors were all administration. So it functioned as like a 300 or 400 bed hospital, because there was so much administrivia that was just going on there that was just ridiculous. So, the VA is a problem. I think it's a huge problem, but it's one of those kind of sacred cows that I think politically is very, very tough to address.
What kind of EMR do you have
At the NIH? It's called CHRIS, and it's the only one of its kind, supposedly. It was designed specifically for the NIH. And the nice thing about CHRIS is that it has a clinical research mechanism to it so that you can put in a test and every patient on a particular in a protocol, and every patient on a protocol, you can pull the results of those tests out, all of them, and it takes about that long. So that's kind of nice when you're doing clinical retrospective research and that kind of stuff.
Can't get anything done at NIH, even when you go in for a cysto, say when some of these bullet close dignitaries come in for a scope, they still have to sign up for some protocol, unless you're on a protocol.
Everybody's on a protocol of some kind.
You cannot be cared for. So we have to, sometimes we have to be creative to find protocols
Well-
to take care of some of these VIPs who walk in.
And what they do is they create these really amorphous protocols so that you can do stuff like that. So we have a tissue collection protocol. So, most of the research when he and I were fellows at NIH was in kidney cancer, hereditary kidney cancer and that kind of stuff. But you could sign somebody up. Most of our patients would be signed up on a hereditary protocol and then the tissue collection protocol. But if you had a patient who came in with prostate cancer or penile cancer and you decided you wanted to do the case, you just signed them up for the tissue collection protocol. Because there's like wording in there.
If you had a biopsy or a tissue, they were picked by that protocol.
Yeah, and you would just say, well, we have an interest. We may do research on this tissue later. And so you sign them up for that.
Care without being on a protocol.
Yep.
So that makes that EMR very
But yeah, the protocols are this thick. And you got to, you have nurses who spend time with each patient kind of going through the protocols with them and getting them to sign it and that kind of stuff. So, it's not efficient. Not surprisingly. Yeah. You know what NIH stands for, by the way?
National Institute of Health.
No, not in a hurry. It also stands for Nerds in Heaven or Nerds and Herds, either way.
That's here too. Thanks for that talk. It was great. A few things you touched on, and sort of like when we look back after we've been in practice for 3 or 4 years, a lot of this stuff is really evident. We're like, damn, I wish I knew that when I was looking. What do you suggest? Because when we look at residency training programs, at least the classic ones, we're sort of in this ivory tower. We don't have this exposure to all these different practice types. So what do you suggest to residents? When do you start looking? When do you start talking to people? How do you get this exposure to other kind of things that are out there? Because when you say training programs, we're like, we want to be here to teach residents, and this is what our passion is. How do you get that other exposure?
I think that's a great question, and the short answer is I have no idea. One of the reasons why I'm sort of focusing on these guys in the front row here is because I never thought about this stuff when I was a resident. My big thing was, how many cases am I going to do? What's the next case I'm going to do? I want to, and so I wasn't really thinking about these issues. And so if, you can sort of break that sort of myopic focus on, what's the next case, or, what's this disease process I need to learn more about so I can do better on the in-service kind of thing, and start broadening your view.
The interns and the younger residents.
Yeah, well, it's really important to do those things. It's incredibly important. You got to get those skill sets, but you're going to get them. You guys have the volume. You have the teachers. You're going to get those. But when you have the opportunity, particularly if you rotate out or you get a chance to talk with some of the local private practice guys, ask them these questions. You don't necessarily need to talk to them about, a caval thrombus case. You got a guy here who can tell you everything you ever needed to know about that, right? So, talk to them about the stuff that you're not going to get here. Ask them about how the practice is set up and that kind of stuff. They're more than happy to tell you that stuff if you ask. I never thought to ask when I was that age and stage. And when you get toward the end of your residency and that kind of thing, you obviously have to make decisions about whether or not you're going to do a fellowship, what's interesting to you, and that sort of thing. And that's the time when you start really picking the brain. When you go to meetings, find people that are in different practice models and talk to them about it. Because that's the only way you're going to figure out sort of what fits for you and what doesn't fit for you. But in the next, couple, 3 years, you got to figure out what that one thing is that really gets your juices flowing. I figured out very early on I didn't want to be a generalist. Within the specialty of urology, I realized that, there was about 2/3 of it that I just had no interest in doing whatsoever. And so I was like, okay, I got to do a fellowship so that I can have a little certificate on my wall that says I don't have to see you. I'm going to see these people over here that I actually really enjoy, that gets my juices flowing. I like the big cases. I like the oncology stuff, and I'm sorry if you can't get an erection. I got a buddy, Dave Fennig, the one guy who's still in Chesapeake Urology. He loves that stuff. Go see him. He's much better at it he'll do a better job for you on that than I ever would, because I frankly just don't care. Sorry. you know. And so you gotta figure those things out as you go through.
So there's one other. First of all, I really enjoyed your talk, and it reminded me of my first job. I was with a big pediatric urology private practice. There were 10 of us in the New York area. We went everywhere, and so that map, I was like,
You had flashback, a little PTSD.
yeah, I remember having privileges at 12 hospitals and not seeing my office for 3 months.
Yeah.
And so it was a very interesting thing. Well, the one thing that is also that I sort of morphed into halfway through my career was this new sort of masters of, health, MPH, morphed hybrid that does benchmarking, quality improvement, and, flow improvement and standardization of practice stuff. And I think that there are, if you're into that kind of thing, and it was big with the ACA, I guess, and there was a big push for that, and who knows where it's going to go at this point, but I think if you're into that, there's a fair number of my colleagues that are, coming through and rocketing through leadership positions based on that. And if
Absolutely.
that's the thing that floats your boat. That's a huge thing. It took me 3.5 years to get my master's.
So then, to coattail on that, right now we are working on a program through UT,
Right.
which should go probably live, I think, this year or next year, where residents can get a combined MBA through UT and focus that maybe on healthcare or some other arena.
They had that at Wake Forest, and I kick myself every time this topic comes up that I didn't spend that extra year to get my
Right. And they're
MBA.
offering it in med school as well,
Yeah.
sort of MBA, MHA, MPH,
Yep.
MA, MS,
Yep.
everybody has
But
their,
one of the things is that there are few opportunities. So one is that, the second is that if you look around the country, the only reason I'm aware of it, 2 years ago, I had the bug bite. I even applied to every MBA program and then I pulled out. There are few places in the country where you can even say if you start a practice or you want to do fellowship, they have these 3 months, 8 weeks, 12 weeks intense, very healthcare focused. Harvard has one of them that you can go in and probably get, because those skills are more valuable now than they have ever been. So that's one, we have it locally, so you guys should kind of keep your eyes and ears open if you're interested to the GME office.
I strongly encourage you to do those kind of things, even if you don't want to get the full-fledged MBA. If you can take a time, 6 weeks, do these courses and stuff to learn the business of medicine, I think it's a great use of your time. I don't know anybody who's done it who said, wow, that was a waste of my time. Not a single doc that I know. Now, to add to your point, if that's something you're interested in, I mean, there are tremendous opportunities because every single one of these big practices in particular, but even the littler practices, hospitals, they're all looking for, efficiency of delivery. And so if that becomes a thing that you really like and you're interested in, there's a huge need for that. It's a great market niche you can fill. I personally wouldn't be happy doing that. That's not something I would want to do. And so, it's, again, that one thing, Curly Bill. If you haven't seen City Slickers, you really should watch it. It's cute, especially if you have kids. That one thing, you find the thing that makes you go and then sort of build everything else around that.
And AUA also had, to get that Ronan's point about resident education, so AUA now has this whole practice development thing they put together every year as a meeting for residents. It's usually open to the last 2 years, where you can go and kind of get a intro, like a little flavor into practice patterns, opportunities, coding, so on and so forth, but you guys kind of have to be aware and seek it out. Anyway.
Yep.
So thank you very much. That talk was great. I didn't know almost anything that you said, so there was a lot of learning to be had for me, and I'd love a copy of that slide set.
Sure.
Yeah, I was gonna ask you.
Absolutely. I'll email it to you guys. That's no problem.
I realize that one thing is something that's different for everybody, but you knowing what you know now and your knowledge of all these different areas, if you were graduating from residency or from fellowship now, what would you do?
That's a great question. And it's a hard one to answer because, we all make decisions and compromises in our life, right?
Sure.
So I'm living in an area that I think is really tough to do a true academic practice. That was my original goal. I mean, there's an old saying, and I don't care if you're atheist, agnostic, or highly religious, just don't be offended. But how do you make God laugh? Make plans, right? So coming out of my residency, I wanted to be a bladder cancer guy. You know, I wanted to do translational research, wear the two hats. Basically, the Peter Black, the guy, I wanted to be him. You know, now it's funny because we're colleagues, we train together, but you know, that his practice is kind of what I wanted. But there's no opportunity to do that, or virtually no opportunity to do that in the DC, Baltimore area. But I'm there because, you know, I was married to somebody who was working in that area. That's where I needed to be. And because we moved there, I ended up becoming kind of a kidney cancer guy, and I actually really like it. I'm happy that I'm doing it now, but you know, I had no idea about that. So, coming out of residency, so you know, in a perfect world, taking all the personal life stuff out of it, I probably would have stayed at Anderson and then found a job at a university setting, probably somewhere in the kind of in the middle of the country, where I think the true academic practices are still thriving to some degree, more than they are on the coasts. I think it's a little, you know, things start on the coasts and kind of work their way inland. But, you know, the financial pressures and these hybrid practices that you see at Georgetown and GW, I think are becoming more and more the rule in the more populous areas, and in the less densely populated areas, the true academic model is still in effect. You know, and so I would probably do that as opposed to kind of what I did. I never had any intention of going into a private practice and doing what I ended up doing, but that was really the only option that I had at the time. You know, and the large group that I joined, there was, you know, in hindsight's always 20/20. There was a way for me to make that work. I didn't see it, and I didn't set myself up to succeed that way because I didn't know what I didn't know. You know, and so, you know, there's a way to make that work, and I probably could have found a certain amount of satisfaction there. But the research that I like to do is not, you know, pharma research, kind of phase 3 level kind of stuff like that. That's not really the thing that floats my boat, but that's what I would have been doing if I'd stayed and done that. You know, and that would have been okay. But that doesn't really get me going like when I was in Dave McConkey's lab at MD Anderson, and, you know, we're looking at apoptosis pathways, and I'm, you know, working with silencing X-linked IAP, you know, the inhibitor of apoptosis proteins, and CIAP and MLIAP. I mean, that's like the happiest I've been since I, you know, started in medicine. That was great. I love that. And you know, if I had an opportunity to still do that, that'd be great. You know? Yeah.
I don't think it's a good idea to spend your life now. Right. And be open, keep your eyes up, and look out on the horizon, and do what you think you need to do tomorrow, the next day, the next year. I always thought with plans, people work with people, we need a 5-year plan. My thoughts, they'd say, well, I'd say, go ahead and do it, but I'm gonna figure out what I need to do today and tomorrow to accomplish what I want to accomplish. So don't get yourself focused in on, 20 years from now I want to be doing this. I'm not ever gonna, because it's a big world out there. And
Yeah.
I think because there's such a shortage of urologists, you guys are gonna have an opportunity to move in any direction, and you don't have to get going one way, you can still turn around and go the other way. That's the way I look.
I think there's a lot of truth to that. The thing that I would add is simply that, you know, just keep your eyes and ears open and sort of try and absorb as much as you can from the people who are doing different things, because you'll eventually figure out what really appeals to you, you know, and you know, you don't want to confine yourself to a set plan. This is step A, step B, step C kind of thing, because, you know, that can be limiting. You want to sometimes consider step X that didn't even occur to you. Like, you know, I ended up being a kidney cancer surgeon. I never would have done that if I kind of stuck to the original plan. And I really enjoy what I do. So, no, I agree with that. Sure.
Thank you, Adam.
Absolutely. Thanks for your time.
These guys have conference right now.
Yes, sir.
Yes, sir.
I think that might work.
Absolutely.
You guys want to pick his brains, hang out?
Yeah, that'd be great.
Ask you about a couple of things.
Yeah.
So,
Or if we want to.
I gotta-
This thing, but-
around it earlier, but she'll go to hours today.
Really ought to. No, it's loud.
Great results in the past.
Not that I'm aware of.
Perfect, and then, he'll be under, and then the other one is this guy is still.
Do they have a place in here about?
They said young urologist forum, and it's like, they have like fellowship trained guys, well, feed them and talk about it when I was.
Feed 'em today.
They actually
Take the
gave you a
cats.
stipend to go, $500 stipend,
See
whoever
what's
goes for the residency program.
And if it gets clogged,
I forgot my disclosure. In full
Okay,
disclosure,
sounds good.
those last few slides I actually stole from Sandy Siegel.
Yeah,
Who was the head guy in Chesapeake Urology who came
Oh,
to
yeah.
talk, like, they were doing a pro-con academic